My name is Jesus Berdeja. I'm the Director of Multiple Myeloma Research at the Sarah Cannon Research Institute. I'm an attending physician at Tennessee Oncology and the Sarah Cannon Center for Blood Cancer. Although multiple myeloma is an incurable disease, there have been significant strides in both the diagnosis, treatment, and supportive care of the disease that are allowing people to live much longer. And the good news is that the median survival of myeloma has doubled and maybe even tripled in the last 10 to 15 years. So as more and more people live with this disease, it's becoming more of a chronic illness. And that is the hope, is that people actually come to attention early enough so that we can actually address and treat the disease before it leads to conditions or symptoms that are irreversible. Because if the patient has no symptoms from their disease and it's treated, the goal is to keep it in remission and make it into a chronic illness that the person can live with, similar to having hypertension or diabetes that is well controlled on medications. The treatments for myeloma are various, and they range from chemotherapy and steroids to what we call the novel agents. So up until about 15 years ago, all we had were some basic oral chemotherapies with steroids that worked very well but didn't work for very long periods of time. The current treatments are more based on these very specific drugs that address the myeloma and kill the myeloma cell in different ways. One class of drugs is the proteasome inhibitors. And the proteasome inhibitors basically don't allow the cells to clean house. So as protein accumulates in any given cell, the cell needs to excrete that protein. If you don't allow it to excrete it, the cell will die. Well, myeloma cells are incredibly sensitive to this process, and so the drugs that inhibit that clearance of protein are very important. The most widely used and the most common proteasome inhibitor that people are probably most familiar with is a drug called Velcade or bortezomib. Since bortezomib, there's been another drug, a second-generation proteasome inhibitor that's been FDA approved just 6 months ago, called Kyprolis or carfilzomib. These drugs are very potent against multiple myeloma cells and by themselves work very well against the disease. But we know that in combination with other drugs, they are even more potent. The drugs seem to accentuate themselves. One of the drugs that works very well in combination is a steroid called dexamethasone. And dexamethasone will mostly, for most patients, will be part of the regimen that is combined with the proteasome inhibitor. A third class of drugs is called the IMiDs, or immune modulating drugs, and the first of its kind that was available was thalidomide. Thalidomide people may know as a drug that was very widely used in the 50s and 60s and was given to pregnant women as a sleeping medication and led to many birth defects. That drug went off the market, of course, at that point, but it turned out many years later in the laboratory that this drug actually had very potent anti-myeloma effects. And so this drug was basically renewed and was reborn in the treatment of myeloma. Since thalidomide, there's been new generation drugs that have come out into the market, and now thalidomide is rarely used. Its new generation, lenalidomide or Revlimid, is probably the most widely used IMiD. And so people will probably know that drug better. Since Revlimid, there's been a newer generation IMiD that has just been FDA approved called Pomalyst or pomalidomide. All these drugs work very similar. They seem to starve the myeloma cells. So myeloma cells love the bone marrow. They seem to stay there. Unlike other diseases where they jump around or they circulate, plasma cells don't like to do that. They're very dependent on the nutrients they get from the bone marrow. So these class of drugs, the IMiDs, seem to actually block those nutrients and they starve the cells. So together in combination with the proteasome inhibitors, the steroids, and the IMiDs, you sort of attack the cell from different angles, and we're getting very impressive results with these combinations. Because multiple myeloma can affect many different organs, including the kidney, the bones, the immune system, it is very important that a multidisciplinary approach be considered. People come at very different stages of their disease. Some patients come in feeling quite well and surprised that they have a malignancy. Other patients come in very debilitated and very sick. So it's very important to not only address the disease itself and the treatments, like as we have discussed, but also to ensure that the patient is able to tolerate these treatments by ensuring that they get stronger and become more independent so that they can access the most aggressive treatments possible. And one of those is nutrition. Nutrition is very important in all cancers and as well in myeloma. There are no known specific nutrient deficiencies, but there are very specific things that should be avoided. I just told you that multiple myeloma, unlike other cancers, tends to lead to hypercalcemia. A lot of supplements often have calcium supplements, which could be a dangerous treatment or supplement in this condition initially. Part of the treatment for myeloma is to address the bone resorption, and patients will often go on this drug called bisphosphonates that will start building bone but will also cause hypercalcemia. So at some point in the treatment of this disease, you will have the opposite problem of the original presentation, which is hypocalcemia, and at that point supplements are important. And so having someone guide and address these issues ongoing is incredibly important to ensure that you are not hurt by what seems to be a simple process, such as nutrition.